I can personally say that even the morning 2 sessions stirred up a lot of questions, a lot of thinking, reflection, even whether we are doing things on the right way, on the right track. And I'm sure that the rest of the conference will bring even more of these questions. Not sure, I hope a lot of answers also to these questions, but definitely will be putting a lot of question marks to our work. And the next one who will do that is my dear colleague and friend, Dr. Saška Roškar, who comes from the National Institute of Public Health from Slovenia. And she is the person who is leading the interdisciplinary working group for suicide prevention in Slovenia. And also a person who has been instrumental for probably 2 decades at least. I'm now counting the years of engagement in this field. So Saška will bring an interesting point of view that in a way she already addressed at the conference, the World Conference that we have had in Slovenia, but maybe updating it a little bit about the strengths, limitations, and challenges of contemporary suicide prevention. So it's in a way building up the program from Heidi, Diana, and now Saška with this little bit critical point of views on the current situation. Saška, thank you for being with us. I'm looking forward to the lecture and to the discussions afterwards.
Hello, thank you, Vita, for this nice introduction. I myself would have made it much more humble, but you're the boss here. I would like to thank the organizers for inviting me, for giving me the opportunity to speak, which is always a risk, giving me the word. But nevertheless, for me, it's a very emotional situation to be able to give a talk at the conference, which is addressed in the memory of my mentor, Andrej Marušić. And Andrej always used to say that our eyes are placed in front, so we can look ahead, we can look into the future. And I think that the topic of this conference brings it very nicely together. A lot of innovative aspects, topics, and so on. I can hope I can add a little bit to that. Yes, what can I say? I am still recovering after Heidi's brilliant presentation. She was critical to the point, as always, and I'm afraid that everything I will say now will come across as very omnipotent. But I feel like I can retire. I have nothing else to add, but nevertheless, I hope that I can also offer some food for thoughts. As Vita already said, my presentation will be partly or mostly a repetition from the talk I gave at the YASP conference in Piran. So I apologize in advance to those of you who had the opportunity to listen to this talk at the YASP. I tried to embed few refreshments into the presentation so that some new things will also be there for those of you who already listened to the talk. And last but not least, my biological equipment is not operating as it should. My throat is not at its best at the moment, but I do hope that I'll be managed to deliver the speech. So let me see if I can share it. Just please, Vita or someone from the organizers, if you can just give me a sign if you can see my presentation in the presentation mode.
Yes.
It's okay. Good. Done. So I will try to offer a critical view, both positive and negative, on where the contemporary suicide prevention at the moment is standing. This is kind of our route planner. I tried to put the topics together so that they will reflect the main theme of the conference. So our suicide prevention efforts this time to stagnate. I will first talk a little bit about the state of the art of the suicide prevention. I will then address a little bit the strengths. I will also mention the limitation, and from there on, I will try to look into the future or discuss what are the ways we can push the whole thing forward and do or try to do them better in the future. And with a bit of luck, after 40 minutes, our aim will be achieved. But I don't know if on the right or on the left side. Let's see. Okay. So where do we stand with the suicide prevention as now? As already has been heard, also from the critical standpoint, at this moment, we know a lot about why suicide, at least at the populational level. This means that we know a lot about who's more dangerous, which are the risk group, what are the potentially threatening circumstances, and above all, what are the risk factors. And according to that, we managed in the last decades to develop more or less good prevention effort at different levels. We know that the factors contributing to the heightened suicide risk can be either on the micro level, on the meso level, or on the macro level. And then according to that, the contemporary suicidology has developed interventions. There are interventions which are primarily on the individual level. These are mainly delivered through the clinical sector, crisis intervention, treatment, follow-up, and so on. Then if you move up to the meso level, we have mostly institutional interventions focusing on primary healthcare screening, institutional interventions, gatekeeper support, which we already heard of today. And if you move even further up to the macro level, to the community level, societal level, here we have broader intervention like means restriction, media guidelines, awareness, destigmatization, and so on. Now, and as I said, these interventions we developed can be more or less effective. And when it comes to effectiveness of the intervention, I like this quote very much. It's by Milton Friedman. He was a US statistician and economist. I think he even got a Nobel Prize. And he's thought to say that one of the greatest mistakes is to judge the policies and programs by their intentions rather by their results. So from here on, I will try to take two routes. I will try to deliver a judgment based on the intention, and then to deliver also a judgment in the brackets, not really a judgment, but opinion. What do the results say? So if we first move to judging our efforts, and the broadest efforts in this field are packed within National Suicide Prevention Program. And if we try to judge them first by their intention, then what we know is that National Suicide Prevention is to date the most comprehensive and integrated national response to the problem of suicide mortality within a country. And we do know that just under 40 countries at this moment do have a National Suicide Prevention Program. Professor Platt, in his paper, presented this table. It summarizes why a national suicide prevention is needed. I don't want to go much into the detail, but basically a national suicide prevention strategy is needed because it demonstrates clear government recognition that suicide prevention is a problem in a certain country. And above all, it pinpoints who has to do what in order to tackle the problem. So to answer the first question of the main theme of the conference, if we judge the national suicide prevention by their intention, then I think that no stagnation is foreseen because the intentions are clearly good. Now, what about the results? If we judge our efforts based on the results, then a slightly different picture emerges. I've listed here 4 studies which did the immense effort to see what the evaluation of national suicide prevention shows. And the first study found that after the initiation of suicide prevention program, the suicide rate decreased in Finland, while there were countries where suicide rate after the initiation has increased. Other studies found, other studies found similar results. There were countries in which overall suicide rate has decreased after the implementation of National Suicide Prevention Program. This was particularly noticeable in certain subgroups like in young, in elder, and in men. But there were other groups of population where the initiation of National Suicide Prevention programs seemed to have had no difference. Then there was another study by Levitska and colleagues who found pretty much similar as the study by Matsubayashi and Reda. And there's the most recent study by Schlichthorst and colleagues who found results in both directions. So that there were countries in which suicide mortality decreased as well as increased after national suicide prevention strategy was initiated. So these results are kind of mixed, and I will add to that because somewhat intriguing is that if we consider the national suicide prevention strategies as the holy grail of suicide prevention, we know that there are countries, Slovenia is one example, that in the last decades there were witnessed of suicide decrease in the last decades with no whatsoever dedicated suicide prevention efforts. Slovenia had no suicide prevention strategy in the last 20 years, and yes, we witnessed like a 30% decrease. Now, if the whole package does not work, we can look whether certain components of this package works, and of course studies were done in this field. There are many studies, predominantly RCTs, in which the authors try to have a look which of specific components are effective and which are not. And what the studies have found is that from those typical components which are listed in the left column, for some of these components, the studies report that there is enough evidence of their effectiveness. For some of those components, studies found that we need definitely more evidence, and there are some studies who, for the same components, found like mixed results. I want to draw your attention to this study I already mentioned, the study by Schlichthorst. I cannot see myself right now, so I don't know if you can all hear me. I'm referring to my voice. You can hear me, okay. So the study done by Schlichthorst and colleague had two levels. First of all, they conducted a narrative review of suicide prevention programs in 29 countries to pinpoint which are the most typical components used. And they found that the average number of components in those national suicide prevention programs in those countries ranged from 4 to 11. But what I found really striking in this study was the second part. It's the part where they conducted a statistical analysis in 24 countries, and they were interested in if there is a contribution of those individual components to the reduction of suicide. And I think this is the first study of its kind. Now, what the authors find kind of struck me, and I can say that the longer I am in this field, the more I have the feeling that I know nothing, or that I know less. It should maybe be the other way around, but honestly, the more I read into it, the more I think how much I don't know. So what the authors found, and this is their conclusion, is that they were unable to identify any specific suicide prevention strategy component to be associated with a reduction in suicide rate. To me, this was really surprising. One can ask, do we even know what we are doing? Now, the only difference they found is in regards to crisis intervention, which, as you can see, was adopted only by 37% of the countries. But even this difference was no longer considered significant after they made adjustments for multiple testing. And now I want to draw your attention to another component, and this is awareness raising, which again, as you can see, in comparison to crisis intervention, is adopted by a high number of countries, or a high percentage of countries. Only 82% of countries are adopting awareness raising efforts, because it's an easy thing to do, and we think that the more people know about that, the better for us. But is this really so? I came across this rather challenging paper or thought-provoking paper in which the authors place a hypothesis that there is a cyclic relationship between our awareness efforts and the prevalence of mental health problems. It's not directly related to suicide awareness, but nevertheless, I think when we engage in awareness raising about suicide, we very often do this by referring to mental health problems. So what these authors note is that in the last year, there was an increase of awareness programs. And at the same time, what we do notice is that there has been an increase in the prevalence of mental health problems. So how so? Are we achieving exactly the opposite as we want to? And in fact, that's what the authors claim, that in a way, we are trying to catch our own tail. And because firstly, what happens is that we notice as public health professionals, clinicians, in whatever role we are, that there is an increased rate of mental health problems in the population. And of course, the logical response is we need to do something. And what's the most easiest thing to do is to offer a program to increase the awareness in the population. But if we deliver a program that increases the awareness in the population, this can have a side effect in a way that the people will be better at recognizing their problems, but there will also be an over-interpretation of their mental health difficulty. Basically, they will interpret normal emotional states, normal, let's say, not so positive mental states, as something that needs to be checked by a professional. So it's a pitfall that we need to bear in mind in our field. And the authors, it's just a hypothesis, and the authors propose very nicely that that this hypothesis needs to be empirically tested. But above all, we have to be mindful of potential adverse effects, even of something as harmful as an awareness program. And there's another paper which more closely refers to the topic of suicidality, which is also critical of the way we address this issue in the public. In particular, these authors focus on the population of students and their mental health. And the message that they try to convey here is that the very narrative, the very crisis narrative that we use when addressing mental health of students might contribute to the rise of the problems within this population. And they call for a more balanced approach, balanced view between those two approaches, between overly pathologizing, medicalizing students' mental health problems, and between other public health approaches. So I started my presentation with trying to refer to Milton Friedman's quote. And I said that if we judge, not really judge, but if we try to evaluate our programs on the basis of their intention, that then there is no stagnation foreseen, because our intentions are clearly good. But if we summarize everything I just said about the results, and I've said that the evaluation of the effectiveness of national suicide prevention programs yielded mixed results. At best case, they seem to be promising rather than convincing. DeLeo and Evans even wrote in the paper that there is more evidence for negative impacts than either positive or neutral impact. We also seen that the study by Schlichthorst and colleagues found that neither of the components seems to have had a direct relation to suicide mortality decrease. Then we can say that if we judge our intention by the results, then maybe not stagnation is foreseen, but that at least we need a revision. Now, how can we approach this revision? What can we do about it? Now, the first thing we need to know very well why our program with such a good intentions do not deliver results that we want to see. And here I came up with this analogy of the linguistic professional Chomsky, who said that when language is developing in a certain phase, we are speaking of a black box. Something comes in, language comes out, but in the midst of all this, it's a black box where the language is formulating itself and nobody exactly knows what's happening. And then reading through the papers, particularly the paper by Platt, Arisman, and Rezayan, I'm quite sure I did not pronounce this very well, they listed all the possible factors which can go on in this black box, contributing to why our national suicide prevention efforts are not having such results as we want to. This is why I was a bit of playful and named this Platt, Aronson, Rezayan black box in suicidology. Now, we know of the components we refer to when putting together national suicide prevention strategy, and this is our input. And we have a very clear vision, a very clear idea what we want the output to be, to decrease in suicide, also decrease in suicide attempt. But this is very often not the case. So something is happening during or between our input and our output. And what can be happening and contributing to our programs not having such effects as we want to is listed here. This can be due to temporary fluctuation in suicide incidents. It can be due to unavailable, or unreliable data. It can be due to that the timing of the implementation of our effort was not the best. Very often what happens that we notice a decrease in the, a deviation in what we thought to implement and what we actually do implement. There are other covariates which we do not control, and also there's a complexity of national suicide prevention programs itself, which contribute to our data, our efforts, in this field not being as optimal as we want them to be. So next to that, next to this black box, I was thinking further what can be other limitation, other drawbacks of the current approaches we take in suicide prevention. It is beyond any debate that our strengths lie in that we know the risk factors and that we are very good in forming prevention strategies at different levels. But the problem is that the most, I will not say all of it, but most of what we do in suicidology field at this moment focuses on the point where the suicidal process in a person is starting to develop. So most of our efforts are aimed at preventing the suicidal process to develop or to progress. Our mindset is such that we are gaining ever more knowledge on why persons die by suicide, meaning that we are more inclined to research the risk factors. Our actions do lie on different levels, on the micro, meso, and macro level, but the empowerment, if we look at it from this way, mostly lies on the individual. Recognize your distress, and if you do, as Heidi said, the main message is seek help. It's a necessary thing to do, because when people are acutely suicidal distress, or even not acutely suicidal distress, of course we need to address all what I just said. However, if we are focusing only on this part of the line, suicidal process is development taking place, everything we do is from the standpoint of the prevention. And if we address these issues from the standpoint of the prevention, we are addressing it from the pathogenic model. And all preventative efforts take mostly place in the health sector. But we know that mental health development and maintaining of mental health is an issue which is very broadly and applicable and important, not just to the mental health sector. And in prevention, we are mainly interested in what causes a condition, why people die by suicide, how can we treat whatever is the underlying condition. And I think this is a short-sightedness of contemporary suicidology. Now, the idea I'm proposing from here on is, but before I go to that idea, I have to show you a paper which kind of summarizes the critique I just presented you. And it's a paper that prevention maybe is not the best cure. Now, prevention in the last couple of decades was the mainstream, was the mainstream, sorry. But in this editorial, the authors argue that maybe exactly because we are focusing so much on prevention, we are missing some important points. And one of the important points that we are missing, and particularly in young people, which Diana gave a brilliant talk about, and also this paper refers to, is that if we just do prevention, if we just screen for problems, if we just fish out the individuals who are at risk, we might be missing or at least delivering limited attention to something else that is also very important. And these are positive capacities, positive skills that each of us possesses, and in particular the resilience. So it's kind of becoming clear that if you want to decrease problems in this particular point, we are speaking about suicidality, then maybe just prevention will not do. And here I started to think about that, okay, I said that our strengths lie in the fact that we know a lot about the development of suicidal process, which we try to prevent. But what if this exactly thing that we focus so much on the development of this process, which is our strength, at the same time presents that this means that we are a bit short-sighted, and this is a limitation. Namely, while focusing on the part and on the population which are at risk, and focusing so much on the suicidal process not to develop, we neglect a great deal of population. And all that population is, in a way, we can say, in a waiting room. At this point, they are okay, but we are not delivering enough to them to keep them that way. But once they cross the line, and start to develop the suicide process, then our attention is directed at that. So there are a lot of people who are okay, they are in the waiting room, we not deliver enough interventions to them. We don't pay enough attention to why suicide is not happening. What are the protective factors in those people? What makes people not to reach the decision to end their life? And here I am proposing that also suicidology gets a bit more open, inclusive to a field which seemingly has not much to do with suicidology, and this is the field of promotion. Now, mental health promotion is often understood as speaking about mental health, but mental health promotion is a much broader concept, which in its basis has to do with enabling life conditions in which individuals can thrive. We have to empower the individual, and above all, we have to enable such living conditions that this empowered individual will be able to live the healthy choices that we teach them to do. Now, if we move to the field of the promotion, first of all, we move outside the health sector. We move to all sectors where people live, where mental health is taking place, where mental health maintains itself. And our core question here is not how to prevent something, but how can we maintain a mental health person to stay that way. So it's a totally different approach from prevention. After my speech at the YAS conference, I was approached by Professor Steve Platt, who didn't quite understand my idea, but we met at a Zoom meeting, and afterwards I explained myself to him. We kind of came to an agreement that mental health promotion indeed is very different from prevention, in particularly from universal prevention, which many times people think that it's overlap or it's the same. It often does overlap, but it's not the same. So why do I argue that even suicide prevention should include some salutogenic components? Because to prevent is and to treat is not the same as to strengthen and maintain. If we promote mental health, if we strengthen mental health, then we do prevent something, some adverse effects to happen, but not vice versa. We can ask ourselves if the absence of a risk factors per se is also protective factors and vice versa, and we will very rapidly arrive at the answer, no, it's not the same. We know that a prior suicide attempt is a risk factor, but does that mean that a person who does not have a suicide attempt in their past, is that a protective factors per se? No. We know that having a mental illness is a risk factor, but does that mean that someone who does not have a mental illness, so the absence of a mental illness, is a protective factor per se? No. Then again, a lot has been said about cohesion. I will come to that a little bit later. I'm checking my clock, my watch in between. And there's a concept that recently a lot of researchers are drawing their attention to, and this is the so-called concept of the flourishing mental health. And indeed, studies have been done in regards to flourishing mental health, that interventions which did not focus on prevention of mental disorders, mental stress, and so on, but rather on strengthening mental health, on strengthening the flourishing part of mental health, have resulted in decrease of depression and anxiety symptoms. Now, this concept of flourishing mental health comes from the dual continuum, where on one side we have everything that is related to mental health, good mental health and poor mental health, and on the other continuum is everything that has to do with mental illness. Either mental illness is present or it's not present. And what we can see in this picture is that both people with mental illness can have flourishing mental health, they can thrive, and the other way around. People without mental illness can have languishing mental health and not be in a good mental health condition. And this flourishing mental health has been the research established that this is the mental health condition which is related to most positive mental health outcomes, to the quality of life, to our academic achievement, to our well-being, how we function with ourselves, with our environment, and so on. And I think the most important take-home message from this slide is that just because we do not have a mental illness, that does not mean that we have a high level of mental well-being. And therefore, to address a little bit of this paradigm shift from prevention to promotion, we need to move our suicide prevention efforts a bit of upstream. This is analogy very often being used, that the downstream approaches most often refer just to treatment. We are standing at downstream and fish out the people who come with the river, and we prevent even more adverse effects to happen. Basically, the downstream approaches, the treatment which are necessary and have to do with just with saving the people from drowning once they're in water. But we know that this is not enough. If we move a bit upstream, then we have the prevention effort. This is already a bit broader than approaches in downstream. In the midstream approaches, in the prevention approaches, some of them I mentioned, and also the previous speaker did. We are interested in how to prevent people from going into the water. But the upstream approaches, the promotion approaches, do not so much deal, as I said, with how can we prevent from people to go into the water, but we are interested in the people who are standing on the shore and ask ourselves, what makes those people not to go into the water? What are the protective factors? So what can we do to enhance these factors in the population as a whole? Now, and indeed, a couple of months ago in Crisis, this editorial was published, which summarizes basically everything I just said. And the authors propose a more holistic, a more broader, a public health, a whole government approach to suicide prevention. And the authors argue that national suicide prevention strategies could be or should be strengthened by an increased focus on the social determinants. And as soon as we speak about social determinants, we are on the upstream approach. But what I like very much in this paper is that the authors also say that, yes, we do have to intensify our focus on the social determinants, but not on the expenses of the intervention, the prevention we already do. So also everything I said is not to say that everything we do in the field of the prevention has to be replaced with approaches of promotion. No way. We have to continue doing everything we're doing now, but I think we have to expand it. Now, to say a few last remarks about what the authors mean when speaking about social determinants, there are many different definitions what social determinants comprise, but most oftenly, social determinants, if you will look it up in the literature, you will find that the authors speak of social cohesion and social capital. As far as social capital and social cohesion is concerned, I think that our first reaction would be that the more there is social capital in a community and the more social cohesion is in the community, the better. But the reality is that there are studies who found things that the opposite way. So there are studies who found that there indeed is an inverse association with suicide mortality and social cohesion, meaning the greater social cohesion, the lower the suicide rate. But at the same time, there are studies who found the opposite, that the greater social cohesion also meant greater suicide rate. And I want to draw your attention here to this paper published by Müller and colleagues. It's a wonderful paper about social dimension of suicide. They write a lot about Durkheim's theory of suicide and make it even broader. And basically, they say that if a community has a too big social cohesion, this is the dark line in the back, this can be as detrimental to suicidality as the opposite, if there are no social tie in the cohesion at all. So again, this is something that at the first sight seems maybe would seem very intuitive. Yes, let's increase social cohesion, but maybe it's not that simple again. So to conclude with, I hope I am within the time limit, is that we heard a lot about, in Heidi's speech, about critical suicidology, and I can relate to a lot that she said. But I still think that there are good things that contemporary suicidology has delivered in the last decade. However, I think that we are at a point where we have to shift our modus operandi from the point where we treat, where we understand suicide predominantly as a problem of an individual, of their mind, and make the shift to treat and understand this problem really as an equal problem of the society, of the outer world, in best case scenario as an interplay between the two of them. So to conclude with, I think that we most definitely have to continue with the efforts as we did so far, strive for making those efforts better and better. But at the same time, we have to be attentive to what works and ask ourselves, okay, why doesn't this work? How can we do it better? We have to evaluate our program. As Heidi said, we have to open ourselves for a more inclusive discussion, and yes, to ask ourselves, is it time to include the new approaches, which can be anything from promotion to everything that Diana has said, or Heidi? Yes, so to be more inclusive to everything that is out there, and at this point we are not maybe including enough. And by saying that, I'm referring mostly to mental health promotion efforts, to doing more research on protective factors, and be interested in social determinants. Okay, this has brought us to our goal. This speech wouldn't, I wouldn't be able to deliver this speech if it wasn't for a great number of people, most and foremost Andrei, who kind of taught me a lot of things I know about this topic today. And there's also a list of a great number of my collaborators who each of them in their own specific way contributed to the presentation I just gave. Yes, so thank you very much. I hope it was interesting. I hope there were some new things for you, and I'm glad that my voice played along.
Thank you, Saška. We are also thankful to your voice and to the wisdom and how you narrated this whole presentation. So it was really brilliant to hear from another perspective how to look at the maybe challenges that we have ahead of us. There are already a few questions. I do have some of my own, but I'll leave that for the last part if there is time. Now, I don't know where you want to start, but maybe you were referring to Heidi before. So I was thinking to start with the second question that says, first of all, thank you for your insightful presentation. And Dr. Helmeland mentioned that the future of suicidology lies within qualitative research and the importance of study participants telling their own story. So what are your thoughts on this perspective? So how do you see that?
Oh, I agree very much. I agree that we can come to the point, I doubt that we ever will, but let's say that we would come to the point where we would know all about risk factors there is to know, but I still think that the decision to take your own life is such an individual decision that there are as many narratives, as many reasons as there are suicides. So I think that bearing in mind the context of an individual's suicide is very important. It is difficult to do that. In fact, I don't know how we could do this on a population level, on a big scale studies. But maybe in the future we can find a way somehow to bridge this gap, you know, to gather everything, all the results, all the insights you get from the populational study and contextual qualitative studies as well. I totally agree. It's a very important issue.
Maybe may I follow up, Saška? Do you maybe have now from the top of your head some examples of this from the stream, from the upper part of the stream that you have shown? What could the voices be telling us in terms of how the promotion could work?
Well, it's I usually make an analogy with. It might come across trivial now, but I will nevertheless take the risk. I often ask the students who is responsible for our teeth to be okay. Is it the toothbrush? Is it the toothpaste? Is it the dentist we visit when we have problems with our teeth? Maybe it's our parents, who teach us how to take care of the teeth. It's impossible to say. It's a mixture of everything. And what our parents taught us seemingly is ages away from the point where we are having a tooth decay. And I think it's the same with promotional efforts in preventing suicide. Mental health promotion itself, it's a standalone field, and some of actions coming from the field of mental health promotion have seemingly nothing to do with suicide prevention, and yet it's exactly what they do. And for example, you asked me about examples. It's good housing policy, it's good employment policy, enabling such living conditions that suicide will not seem like a necessary option today. This is mental health promotion. But of course, again, there's a pitfall if we will only focus again, or too much focus just on that, we will neglect all the contextual and individual factors. So I think, yes, to bridge both, concepts, I think is the key.
Yeah. There is another question that actually kind of follows up on what you just said, Saška. So on one way, what should be the outputs if we are studying the flourishing mental health? So how do we measure that at, the arrow that you showed? So what would be the output then? And there is another part of this question. Would that mean that we are in a domain of positive psychology, which is some kind of a new industry or some kind of industry on its own?
Yeah, I wouldn't say that this is the same as positive psychology. Maybe I know too little about it to give a definite answer, but the first answer would be no, it's not the same as the positive psychology. In regards to the outcomes you mentioned, there are different scales like mental well-being scales, focusing on how we function, in everyday life. It's how we perceive our quality of life. Do we have the feeling that we manage our life? Are we satisfied with life? Things like that.
The positive sides and the
positive sides, or that we deliver more attention also to the time when we are okay. Let's say I have a good mental well-being, and we have to focus on what can we do to keep it that way. But in the contemporary suicidology and the whole field of prevention, it is so that as long as a person is okay, the person is not of interest for community development. And this is why I refer to the waiting room, because today, tomorrow, in a month's time, I can be even worse than I am right now.
We can all be there, yeah. Luca wrote a little bit more complex question, so I left it.
Can I have a look?
Yes.
Let's see it. Okay, you can read it and I'll
read it. Yeah, I'll read it out and maybe you can follow if that's okay. So he says, if an individual misinterprets their emotional states as a mental health problem, doesn't that insinuate incomplete messaging, awareness raising? We should be thankful that individuals are paying more attention to their emotional states. The actual issue he sees, I see, is not that the causes of mental health are increasing. Cases of mental health are increasing, but that within the subjection of reported mental health cases, we observe a percentage of misinterpreted mental health cases. So could we tackle that with improved messaging, awareness building? So it's more like targeting approaches, if I understand correctly.
Yes, I completely agree that we should be thankful that the individuals are paying more attention to their emotional state, because this is our goal. People need to be aware of it, and we have to talk about it. So this is, yes, this I agree with. But the problem is, maybe I didn't explain myself clearly enough, is that we are in a state where everything that deviates from being happy, from being okay, from being a high achiever, even smaller states of sadness that last for 2 days, for a week, or so on, are being overinterpreted by the population we deliver awareness programs to as something that is very serious. And according to the inflation hypothesis I spoke about, what happens is that the persons are directing too much attention to symptoms or reaction, we can say, which are a normal behavioral reaction as something bad happens. And then they kind of get stuck in a vicious circle. They pay so much attention to this that eventually their behavior change, their whole attitude change, and maybe a real mental health problem develops. And there's another downside to that, which the authors emphasize, is that we have to change the culture we are living in, particularly if we're speaking about young people. The message nowadays is it's super okay to be okay, and it's not okay not to be okay. As long as you deliver, as long as you achieve, as long as you are happy, you are within the mainstream of particularly of the Western culture. As soon as your mental state deviates from that, even if we can say that it's a normal reaction, it's a normal developmental thing, we tend to put some labels on it. We tend to, send everyone to a specialist, which produces then again waiting line, because not everybody needs a specialist.
Thank you, Saška, for this. Because one thing that comes to my mind is also what I think we more often now see in the clinical practice, and I discussed this with colleagues from abroad, that a lot of patients actually come and they already know, or they have a diagnosis. They come with a very elaborated list of symptoms. They have checked this online, so they know more about the diseases sometimes than we, the professionals.
Maybe I would call this empowerment. I mean, it's a good thing that we can read, but we are professionals. We are the experts of our own problem, whatever it is that we are facing. But what I try to say here, that not every difficulty we experience is psychopathology. Even if we are sad for a week, for 10 days, maybe it's just a phase. But because we are living in a culture that promotes super trooper happiness, it has not the effect we wanted. I see that Luca posted another question. Yes, I think that's what I was trying to explain, and you put it very nicely, much more understandable in one sentence, as I did in 100.
So Luca said it's coming from the negative emotional state into an identity. So
it's a self-fulfilling prophecy, you can say.
Yeah. Saška, may I just ask another question that I wrote down during your talk? Because you said, and I think we referred to that even in the previous talks, how important the social determinants and social factors are. So living conditions, quality of life, housing, and all that. So it seems like there are so many different sectors that should be involved in suicide prevention. And I mean, we've always talked that it's complex and a lot of sectors, but now it seems that we are even broadening this to, I don't know, the fields that weren't talking to us. So how is that? I mean, how should we go on with this? How is that in practice doable?
Well, I think with exactly the thing that Heidi mentioned, with conversation and with the dialogue. I mean, we have a decision to say, look, suicidology is just going to focus on the time when problems start to develop, because everything else is in the hands of other sectors. And it's an argument that is legit. But if we do that, we have to bear in mind that there are people in the waiting room, which sooner or later will become, this will not sound nicely what I will say now, but it will sooner or later become subject to our field. Or we can say, okay, we will focus most of our attention from the point on where the difficulties start to develop, to the suicide process, but we need to start communicating more intensively with other sectors, to arrive at a point where we will agree that mental health is everyone's issue.
Yeah, so there is a lot of talking that awaits us, and a lot of communication and connecting with people or sectors that traditionally haven't been involved.
Well, in your logo, there are a lot of dots which needs to be connected.
Definitely.
So, again,
yeah, and
vision.
And even a lot of efforts of our center and also for other centers and other programs are really to connect people and connect systems and to connect ideas and in a way. Luca is saying just the last part. So how effective are the programs on establishing communities where such topics are discussed openly? So the waiting rooms become a preventive measure.
No, the waiting room does not become a preventive measure, because if it would be a preventive measure, this means that we would again prevent something. We would either be interested in people in the waiting room who are at risk, who are at greater risk, and even at the most great risk. What we need to do with the people in the waiting room is to figure out what their strengths are, what their protective factors are, and increase our focus towards that, to keep it that way. But the first part of the question, I don't know the answer to.
Maybe after this conference, maybe we'll have more ideas, not to be too optimistic or to have false expectations, but these are little steps that maybe are opening up also to this kind of different ideas. So Saška, I'm more than thankful that you have delivered this. You have some last thoughts to share with us, some last things that are on your mind?
Thank you for inviting me, for giving me the opportunity. It's been a great conference, and you are doing an amazing job. I mean, World Conference in September, 8 months fast forward, another conference, big bow and standing ovation.
Thank you. And it's on the efforts of the team and the motivation of a lot of people. So that is what gives us maybe sometimes the wings to do things. And a lot of, the feedbacks that we are getting, you're now being thanked by a lot of people. And also I can say that I did receive in between from our colleagues the signals that a lot of you are also sending emails saying that we are in this endeavors together. And that is very motivating, I have to say. So thank you for to all the speakers that are bringing these messages togetherness again and again forward. So thank you, Saška, for being a part of this and for being a part of it for so long.